Hello and welcome. We are pleased to welcome you to this live webinar from London. The title of the webinar is Managing Growth Disorders, Integrating Technology into a Personalised Approach. My name is Martin Savage, and I'd like to introduce you to the other members of the faculty. John Weinman is Professor of Psychology at King's College London. Jenny Child, Membership and Parent Manager of the UK Child Growth Foundation, which is a patient support organisation. Rachel Pidcock, Trustee from the Child Growth Foundation. Christine Davis, Paediatric Endocrine Specialist Nurse from the Children's Hospital in Cardiff, and Katie Frost, Learning and Professional Development Coach. So these are the learning objectives. After taking in this webinar, learners will be able to gain a new insight into the underlying drivers of poor medication adherence as related to the treatment of children with growth disorders. Learn techniques that can help support the child and family in addressing these issues, and discover the value of integrating e-health tools for promoting effective management. And here briefly is the agenda of the webinar. I will give a brief introduction on the gaps in current management of growth disorders. John Weinman will follow me, talking about psychological factors predisposing to non-adherence and the human digital model of collaborative care. Rachel and Jenny will then talk about the challenges with adherence from the patient and family perspective. I will then come back and briefly show data showing the contribution of electronic monitoring of injections. Katie Frost will then take over and talk about the training of medical and nursing healthcare professionals to address family interactions related to growth management and specifically to growth hormone therapy. And then Christine Davis will talk about the delivery of practical growth hormone management and patient interactions related to adherence. We will then have a question and answer session, and this is very much an interactive webinar, and we invite you to ask questions, and you have the electronic facilities for doing this, and we will address your questions at the end of the webinar. Continuing medical education, we have accreditation for this webinar, and we invite you to complete your evaluation forms, and having done that, you will be able to apply for accreditation. As I've said, you can interact throughout the webinar by answering the polling questions and by sending us your questions at any time using the box on your viewing screen. And following the completion of the evaluation form, you will be able to receive CME credits. This webinar has been made possible by generous educational funding, and the program is possible thanks to an educational grant received from Merck KGaA, Darmstadt, Germany. So as I've said, there will be some pre-assessment questions, which is really to measure your knowledge at the beginning of the webinar, and the following questions will be asked now and then repeated again at the end of the webinar to test your knowledge. And the correct answers will be revealed during the I am familiar with the latest psychological model, the so-called COMB model, explaining why patients may struggle to adhere to medication. So if you would like to address this question now. Question number 2, patients' self-reported adherence to growth hormone injections is, and again, there are 3 options and there is 1 correct answer. Question number 3, 2 of the core skills needed for motivational interviewing are, and there are 4 questions, one of which shows the 2 correct core skills. So now I'd like to set the scene by briefly talking about the gaps in the current management of growth disorders. My disclosures. And you start by seeing these 2 growth charts. On the left, a child, a girl, aged approximately 8 years, has significant short stature. And you can see that her growth curve, the growth curve of her plotted heights, indicates that she is growing too slowly and her height is falling away from the centile lines. She could have growth hormone deficiency, Turner syndrome, small for gestational age, short stature, chronic renal insufficiency, or some other form of short stature. She may be an appropriate case for growth hormone therapy, which is indicated on the right. She starts growth hormone, she has excellent catch-up growth, and she reaches a normal height, and she has a good adult height. Now, this growth curve shows the optimal management, and we are addressing the issue of growth disorders because long-term growth hormone therapy requires commitment by the patient, the family, and the healthcare professional. And these are some examples of children with specific growth disorders shown under each photograph. And these are licensed for growth hormone therapy in some parts of the world, some licensed by the FDA in the US and some by the European Medicines Agency. And as you see, there is a wide range of growth disorders which are now licensed for growth hormone therapy. What are the aims of growth hormone therapy? Firstly, efficacy. We need to demonstrate catch-up growth. The child needs to be growing normally throughout childhood and through puberty. And we need to reach an adult height for the child which is close to the genetic target height. And we need to show efficacy in terms of increasing the serum IGF-1 level into the normal range. We need good adherence to therapy. We need safety with minimal adverse events. And the growth hormone needs to be patient-friendly. In other words, it needs to be well tolerated by the child. Finally, we need cost-effectiveness. And we need personalized growth hormone dosing using growth prediction models. Well, are we achieving these aims? These are historical data published in 2011 from the Nordic countries. And as you see on the bottom of the graph, the different types of growth disorder, idiopathic, organic growth hormone deficiency, small for gestational age, idiopathic short stature, and Turner syndrome. And the definition of an adequate response to growth hormone is basically a change in height standard deviation score of more than 0.5 during the first year of growth hormone treatment. So if you have a change in height standard deviation score which is less than 0.5, and this is indicated by the green bars, this is essentially a poor response to growth hormone. And this is unsatisfactory. And you may be surprised to see that throughout these range of growth disorders, there are poor responders ranging from 28 to 56%. There are several reasons for poor response. Of course, the diagnosis may be incorrect. The dose of growth hormone may be incorrect. The dose of growth hormone may have been incorrectly individualized for the child, and even the therapy may be incorrect. But poor response is very important to identify, because a poor response means that there is no benefit to the child, and this is a needless use of expensive therapy. Now, in this webinar, we are going to concentrate on an important aspect of poor response, and that relates to suboptimal adherence to the growth hormone regimen. You may be surprised, but poor adherence to growth hormone therapy is common. Adherence is often suboptimal. Up to 82% of patients are shown to miss some injections. Up to 60% of patients may miss more than one dose per week. And finally, we now know that better adherence results in better growth. So the success of growth hormone therapy depends on the patient's ability to adhere to their growth hormone regimen. So I'm now going to pass over to John Weinman, who is an expert on adherence in different medications. And John is going to talk about what causes non-adherence to treatment. John.
Thank you, Martin. Here are my disclosures. And what I want to say from the outset is, if we think about adherence or compliance, we're talking about the extent to which the patient follows the medical treatment and advice. And obviously, in the case of growth hormone, the extent to which daily growth hormone treatment is taken. And there are sort of three phases, really, in understanding the way adherence develops. Firstly, there's a stage which we call the uptake stage, which really describes the way in which the patient begins to take the treatment, and indeed whether they actually start to take the treatment. And we know that perhaps in the region of 10 to 15% of patients never really start taking the treatments we prescribe. And we refer to that as primary non-adherence. The second phase, which is really critical phase, is the way in which the patient, or in this case perhaps the family, incorporate the treatment into the daily pattern of life. And so there is a way in which the treatment can be taken regularly in a way which becomes habitual. And then the last phase really describes how long the patient stays with the treatment. And we know that in many cases, patients may give up after months or years of treatment. And there may be different reasons for these different stages. As Martin said just now, there is evidence from reviews, indeed one very recent review, that there is a very wide range of adherence to growth hormone, and overall we know that there are figures of many as 50, 60, or even sometimes 70% of patients are not taking treatment in a regular and useful way. And the important thing is that there is a very clear relationship between non-adherence and not achieving linear growth targets. So given that we have such an important and a very clear evidence-based treatment, the question is why? Why are patients not following treatment? Well, there are sort of older views, which some of you may be familiar with, and then I want to look at the more recent evidence. The older explanations of non-adherence are really based around the idea that people didn't follow treatment because they didn't really understand or remember what they had to do. And this was often taken to be a symptom of poor communication in healthcare. And so the interventions in those early days were very much about improving communication, improving patient understanding, and ability to remember and plan treatment. And that works up to a point, but unfortunately it's not the complete answer. In fact, it's only a small part of the answer. More recently, I think we realized that there are probably different categories and certainly very different causes of non-adherence. We often refer to two quite distinct types of non-adherence that we call intentional and unintentional non-adherence. I'm going to say a little bit more about that in a minute. And we also know that these different aspects of non-adherence have very different drivers or different reasons. And in a moment you'll see me summarizing those reasons in terms of what we call the COM-B model. And by the COM-B model, we're really referring to the acronym. So C stands for capability, O for opportunity, and M for motivation. So coming back to this idea of intentional non-adherence. So we now know that many patients know what they've got to do. It's not a question of not understanding or not remembering, but they're reluctant to adhere because either the treatment doesn't really make sense to them, or they've got worries or concerns about some aspect of the treatment. And the unintentional factors are some of the older factors: poor communication, poor patient experience or satisfaction with their treatment, poor recall. Some patients have real problems in planning treatment on a daily basis and actually organizing themselves to do something in a regular way on a daily basis. And there may be many other barriers outside the individual. These could be financial barriers or practical barriers. So if we sort of map all this onto this COM-B model, we can see that under capability, we've got a whole range of factors: psychological factors, people not remembering, people not being able to plan. We've also got some physical capability issues, not being able to administer the treatment in a way that's effective. Under opportunity, on the right-hand side of the picture, here we refer to both physical factors, getting access, having barriers to the treatment. These are factors that lie outside the patient, and also psychological barriers such as maybe poor support and communication from other people around. But the real big factors, I think, for many patients, particularly around intentional non-adherence, are the motivational factors. People's beliefs, their negative beliefs which they may have, or their mistaken beliefs they may have about their condition and their treatment, as well as more sort of automatic aspects of motivation, the pattern of habits, the moods that can affect what people do. So given that there are a whole range of factors, perhaps it's not surprising there are a range of ways that we now have of working with families and with patients to improve their adherence. And these can involve both human and digital interventions. So in a way, we've got two strategies that are available to us, and both are equally important. Fundamental, I think, is to use the direct experience in healthcare, to use the consultation to understand the patient's issues, the patient's perspectives, and to maybe anticipate issues around non-adherence, and certainly plan and help the patient and the family manage adherence issues. And then going beyond that, there are a whole range now of digital and personalised interventions where we can use, for example, an initial brief screening questionnaire to identify for each individual patient and or family the particular problems they may be experiencing or may have issues with. And then on the basis of that, we can develop interventions which are tailored to each patient and parents' specific barriers. In other words, to deal with the issues that are important for them. So if we think about the consultation, there's a sort of structure which we'd now recommend that we really need for each parent and or patient to really check their understanding of what the condition is and the treatment they're being asked to take or are taking. And if necessary, if it looks like there are gaps or issues, to make sure that they have a really clear rationale for the need for treatment, why they really do need to inject on a regular daily basis. To bring out any concerns and address those. These could be concerns about all aspects of treatment. And then with each patient, particularly at the beginning, to agree, if they can, a practical plan for how, where and when to take the treatment, to set up that regularity, to set up those habits that can really ensure that treatment flows more regularly. And again, perhaps at an early stage or later stages, to identify any particular barriers for that family. So more generally, I think what we need to do is to identify the sort of factors which cause adherence problems for each individual. And so we can, I think at the beginning and during treatment, we can use very brief screening questionnaires to help people identify issues which are important for them. We can use the information from those screening questionnaires to start a conversation, to really begin to understand what it is that's going wrong or that people are finding difficult in a way which is relevant to each individual. And then we can use some pretty basic behavior change approaches to try and target individual factors. And you'll be hearing more about these later in this webinar. But to do that, healthcare professionals need training quite often in how to use tools. They need to practice the skills of good communication, and this requires commitment. If we go beyond the consultation, the great thing now is that there are a lot of other approaches which are out there which patients and parents can go to on a daily basis. These could be web-based, these could be mobile phone approaches which can be used to support the patient and the family on a daily basis using, for example, daily text messaging, web-based interactive programs which address particular issues and help people develop regular habits. And phone-based support also is available in some of these very widely developed programs which are available now.
So thank you very much, John. And I'd particularly like to stress and also thank you for emphasizing the personalised approach to each patient and each family by the healthcare professional. And let me remind you that you can ask questions during this webinar and just ask the questions and we will address them at the end. So now it's a pleasure to hand over to Jenny and Rachel, who are going to talk about the challenges with adherence from the patient and family perspective. Jenny.
Thank you, Martin. Hello, Rachel and I are going to talk to you about barriers in achieving adherence within the family unit. I myself have a 21-year-old daughter who has Silver-Russell syndrome and growth hormone deficiency. Georgia has been on growth hormone treatment since the age of 3 years. I also work for the Child Growth Foundation as the Membership and Parent Support Manager. Some healthcare professionals do not always have sufficient knowledge, time or experience of the treatment and management of growth disorders, often giving conflicting advice. If a healthcare professional doesn't know or understand the disorder, the patient doesn't always receive adequate or correct information, which may result in the patient or parent not realising how effective and worthwhile the treatment can be, and equally not appreciating the costs involved in growth hormone treatment. Many patients and parents are concerned about the safety of treatment. If the correct information and reassurance is not given by the healthcare professional, this can result in them consulting the web and receiving even more inadequate and incorrect and sometimes worrying information. More accurate information needs to be available regarding the benefits of growth hormone treatment. It isn't just about growth. Treatment has so many other benefits, including improved health and well-being and the improvement of self-esteem. More accurate information of the growth hormone devices is required. The medication is more or less the same regardless of the brand, so it's really important to get the choice of device right from the outset. Size, comfort, storage requirements all should come into play with this, and such as the family dynamics and travel all has an important role to play. Patient choice should be offered wherever possible. If the patient makes a choice, then it is much more likely to be suitable and therefore a stronger likelihood to adherence. The Child Growth Foundation recently conducted an online survey amongst its members, and we received 117 responses. The majority of responses were from patients with growth hormone deficiency, multiple pituitary hormone deficiency, Silver-Russell syndrome, small for gestational age, and intrauterine growth retardation. The two most relevant questions were you offered a choice of growth hormone, and how often does your child miss a dose? We received 111 responses and 31% were not given a choice. In the UK, patient choice is very inconsistent. There are guidelines which are produced in England and Wales regarding growth hormone treatment, which you can see by following the link to the NICE guidelines. The survey indicated that around 58% never missed a dose. The results, of course, may be slightly swayed due to patients who miss injections may be less likely to take part in the survey, even though it was anonymous. The patients with less specific or undiagnosed growth disorders seemed more likely to miss doses. As you can see, this seemed particularly evident with the intrauterine growth retardation and the small for gestational age groups, with only around 30% of patients never missing a dose, as opposed to 78% of multiple pituitary hormone deficiency patients. I will now hand you over to Rachel, who will talk more about the barriers to adherence and also about the benefits of peer support.
Thank you, Jenny. As mum to Emily, who was on growth hormone therapy for 4 years, and also over a decade of helping the Child Growth Foundation and managing the Facebook group that we have, we've seen the same types of common topics come up over and over again when looking at barriers to adherence within the family unit. First, I'm going to run through some of those which we call logistical barriers. So this treatment is a daily injection and should therefore become part of our routine. But what happens when that routine is disrupted, for example with a play date or on school trips when the child's going away from school? Or think again about where a family is split, where you've got mother and father living separately and the child living between two different houses and quite often forgetting to take the growth hormone equipment between one house or another, or perhaps they spend the odd weekend at their grandparents'. Couple this together with the fact that, as touched on before, the results are not immediately obvious, so therefore patients don't really necessarily think about the long-term outcome of the treatment. It's easy to understand why they might think missing the odd treatment here or there is not going to be so much of an issue. There's also the difficulty of making sure that we have a constant supply of the medication. I myself have often been to the fridge, taken out the last box and realised that I don't have any more than 1 week's worth of growth hormone left. I then phone up the healthcare organisation. It's going to take 2 weeks before the next delivery can be made. These gaps, obviously with better preparation, could be missed, but they're quite common when leading and managing a busy household. You might find sometimes that the device is not appropriate. There might be holidays that are not thought about, might be going camping, and how you're supposed to take along medication which is supposed to be kept refrigerated. All of these could be seen as barriers which might explain some gaps in treatment. There's then also a vast amount of emotional barriers which we find. Many of the children receiving treatment are because they have a long-term health condition and they've built up this, perhaps a needle phobia or phobia of other treatments. And they have a cycle of fear of pain and the actual pain of taking the injection. The comfort of these devices in small hands, and some of the devices, they can make off-putting noises. This can lead to a vicious cycle that escalates quickly. Every day, the parent or the carer knows that they have to administer this medication to a young child, or the child themselves has to administer it if they're of an age-appropriate age. And this can lead to a very stressful situation. Quite often, it's quite tempting, therefore, to think it'd just be easier to just give that injection a miss. Longer term, a child might start to feel a bit different to their peers, especially around friends. There's not going to be many of them who are having daily injections. Most of these growth disorders are quite rare. Also, how are they supposed to know when these things are administered at home? It's not often they'll tell their friends, and if they do, unfortunately, it can lead to bullying and exclusion. Changes also change as the child grows up themselves. If they're undergoing other stressful decisions, for example, transition from primary to secondary school, or perhaps when they're a bit older in their teenage years, which are always troublesome, and then with the extra stress of exams, it's easy to understand that on top of all of these daily stresses, having to have a daily injection is something that might be easy to pass. All of these can lead to feelings of stress and isolation for both the children and for the adults included. And this is where I'd like to talk about the benefits of peer support. If you can reach out and find other people, other parents who are going through the same experiences as yourself, you no longer feel as stressed and as isolated. Peer support organisations can support and advise their own patients. They can support and advise healthcare professionals. They can connect together other parents and patients who are going through similar issues. Many of them host social media groups, which means that there's a 24/7 online group of people that you can chat to by way of posing questions. You can ask as a parent if you've got a clinic date coming up, perhaps they have some ideas of how best to deal with that clinic date, and they can go well equipped and well supported into those situations. The peer support groups are usually nationally based, but now in today's technology, obviously there's less of a geographical barrier. In the UK, we have the Child Growth Foundation, and there's the annual convention where you can gather together, physically meet other families, make lifelong friends. There's also the Facebook groups that we talked about earlier, website and helpline. And I have to say that for me personally, when Emily was first diagnosed and throughout the years of her treatment that I've had over the last 17 years, the Child Growth Foundation has truly been a lifeline.
Thank you very much indeed. So I'd now like to very briefly show some data which demonstrates the contributions of electronic devices to the management of patients with growth disorders. This is an electromechanical auto-injector, and essentially the child receives a dose of growth hormone by subcutaneous injection, and this device records every injection that is given. It also communicates the data of recording electronically with the healthcare professional, which allows the healthcare professional to appraise and assess the degree of adherence that the patient has had. And this has several advantages. One is that if you ask a child or family the percentage of their adherence, they will give a reply which is not particularly accurate, and the injection device can accurately record each injection being given. So accuracy is very important. Accuracy is particularly important if you look at children who have been on growth hormone treatment for some time, shown by the pink bars here, because the difference between reported accuracy and recorded accuracy using the electronic device is significant. Also, in this large international study using the electronic device, you will see that over time, the percentage of adherence decreases. During the first year, you see the mean values given by the red squares. Over the first year, adherence is good, but it gradually decreases. So by the time the child has been on treatment for about 5 years, adherence has decreased to about 60%. And there are two key messages here. The first is adherence decreases with time, and secondly, this is an indication for the importance of the healthcare professional to become involved and to introduce patient interaction in order to firstly prevent this decrease in adherence and secondly, to address and improve it. Also, the injection device can give evidence of suboptimal adherence, which is not picked up from a simple growth chart. You see here this child who has Turner syndrome was started on growth hormone. She appeared to respond well. Her height increases into the normal range, and you may think that everything is going fine. But the injection device recording every injection demonstrates above on the green data points that in fact her adherence is suboptimal. And if her adherence had been better, she would have responded better. So I'd now like to move on and pass the microphone to Katie Frost. And Katie's presentation is entitled A Guide to Motivational Interviewing for Healthcare Professionals, a Tool to Support Patient Care. Katie.
Thank you. Well, as a coach like you, I'm interested in really helping people to make healthy choices and decisions in their lives. But I don't think that's easy. And I'd like to share with you some observations that I have about some of the challenges that we face. How can we help patients that find it difficult to make healthy decisions about their lives, especially when those emotional barriers can appear to get in the way and block the logical and rational course of action that could be taken? What influence can we really have with patients and families? If they've decided that they don't want to change, can we really influence that? And why do some patients move forward and others get stuck? Is it something that we're doing or something that we're not doing? And these questions and observations led me to explore motivational interviewing. And I'm really excited about the results. And I'd like to share some of the skills and some of the techniques with you to help you in your consultations with patients and with families to really work with adherence to growth hormone therapy. And we're going to be together looking at this question: what can we do better to motivate patients and families to overcome the practical and emotional barriers that hold them back? Now, I'd like to invite you to participate in a poll. So please get ready to do your vote now. Is it better to hear good reasons to adhere to growth hormone injections from you or your patient? So please vote now. Is it better to hear good reasons to adhere to growth hormone injections from you as the healthcare professional or from the patients? Now, we're going to be coming back to our answers to that in a few moments. So let's look now at what is motivational interviewing. Well, motivational interviewing is a collaborative conversation style for strengthening a person's own motivation and commitment to change. And it's based on the work of William Miller and Stephen Rolnick. It's a person-centered approach. And with this person-centered approach, this is about helping patients and families to create their own argument for change. So it's a structured conversation that you can use to engage patients and families, helping them to pinpoint what they really want to achieve and what will work best for them. It's about drawing out that inner motivation that they have for change towards adherence of their growth hormone therapy. Now, the good news is you can lean into motivational interviewing in your consultations, and it's particularly good for helping to deal with mixed feelings. So, for example, we could take a patient that on the one hand wants to adhere to their growth hormone injections, but as Rachel and Jenny have pointed out, sometimes life just simply seems to get in the way. Or it could be a parent who, on the one hand, of course, they want to support their child with their injections. However, on the other hand, they're put off by some of the battles that they need to face when they're doing that. So let's draw on your experience of making healthy life choices, because this is a way of really understanding something about how motivational interviewing works. So some of you will have made your healthy life choices around perhaps giving up smoking, perhaps reducing your alcohol intake. Some of you might have decided to do more healthy eating. And so I want you to think of those situations and think about some of the people around you that have been helpful and unhelpful. And we're going to start first with answering this question. When you've been making those healthy life choices, how have people behaved around you that you've found unhelpful? And I suspect that some of those unhelpful behaviours have been things like not really listening to you, perhaps asking you questions that you feel are forcing you down a path that you don't particularly want to go, but that you feel the person speaking with you wants to go. It could be that sometimes people apparently have made assumptions about you, and it could be that sometimes you feel that you're being a little bit judged. And when we see those behaviours, interestingly, how do we react? And I think what we do is we actually drop down barriers and we actually resist. So let's look at those people who perhaps have been more helpful to you when you've been making those healthy life choices. What was helpful about how they interacted with you? And I think it's possible that you found that they were really genuinely listening to you and really empathising with what you were saying and seeing things from your point of view and asking you questions to help you explore your thinking and your feelings. And I'm sure that at no point did you feel judged. And those are really the kind of behaviours that we're trying to really get hold of when we're working with motivational interviewing. And we call that the spirit of motivational interviewing, or if you like, the principles of motivational interviewing. So let's have a look at those in a little bit more detail. So you can see that in this diagram at the top we've got the word collaboration. And this is very important in motivational interviewing, that we are really working to partner people. And in your consultations, let's remember that in fact everybody is bringing expertise into the room. So for example, your patients are bringing their expertise on themselves. Parents are bringing expertise on their child. And you, of course, are also bringing your expertise into that interaction as well. So in a sense, we're collaborating together as equals. Let's look at acceptance. Acceptance is important because this is profound acceptance of the choices and the decisions that people are making for themselves. And in motivational interviewing, we accept those choices. In a sense, we guide and they decide. Now, another behaviour that we're looking for is, of course, compassion, which I know you're so good at, that genuine care and genuine concern for the patients and families. Perhaps a new word to you is evocation, and this is a word used in motivational interviewing, and what it means is really drawing out that person's intrinsic inner motivation and commitment and building their belief. And it's amazing because in just using these principles you can get results. So even before we look at the techniques, I've got results just using these because they are really opening up conversations for people and making them feel relaxed and trusting you and building that relationship. So let's look now at some of the core skills in motivational interviewing, and these are important for some of the things that, for example, John mentioned earlier, because we're going to look at open questions, affirmations, reflective listening and summarising, and together they form the acronym oars, and that's a good way of remembering our skills, because what we're doing is we're structuring our conversations using these oars and guiding people and perhaps sometimes nudging them with those healthy decisions. So open questions open up conversations. They're questions like what and how and why, and they get people talking, and that helps you to understand people better and to really understand more about what motivates them, what's going on from their perspective, what their needs are and what they want. So I've got some examples for you here. So for example, you might ask, what are your hopes for your consultation today? And in asking that question, what we're doing is inviting the person to talk about what's on their mind, what their needs are, what their priorities are. And straight away, you're gathering important data and information that you can work with. Or we could ask, I'm curious to learn how you've been getting on with your injections. And that is likely to get people talking about perhaps even mixed feelings that they've got with those injections. And can you hear how that is a better question than, are you getting on okay with your injections? Which is more likely to just get a yes or a no answer. You can ask, help me understand more about why you would even consider changing this. Now, can you hear with that question, we're tapping in more to what's really behind somebody's thinking and their beliefs, a little bit more about their motivation. And we're very careful to put something in front of that why question, just to soften it a bit by saying, help me understand, so that the why doesn't come in too critical. So those are your open questions. Now let's look at affirmations, and we can't get enough of these. Affirmations are about really helping people to recognise their own strengths and the positive beliefs that are going to help them to adhere to their growth hormone therapy. So examples here could be, say for a patient, I can see it took courage for you to try this out today. Now, when you say that, that's making that person feel good about themselves and tapping into their own strengths and beliefs. And that's what's going to be ringing in their ears when they leave your consultation. Or you might say to a parent, your creative ideas around this are very helpful. And that's a way of also helping you reinforce some things that parents are doing that are really helping their children. Reflective listening. Now, this is going beyond not just listening to what somebody's saying or how they're saying it, but what they might be inferring, what lies behind what they're saying, and then playing it back to them and offering it back. So it's tapping into their thinking and their feeling that they might not have said. So for example, you might say, this sounds important for you to overcome. And it's interesting because they might not have said that, but that's what you sense. And when you get that right and you reflect that back, it's like a present for them, and it really shows that you're in tune with them, that you're empathising. And it can lead to further conversations. Sometimes people really don't know what to think or what to feel, and they'll tell you that. And it can be useful to facilitate them by asking, I'm wondering if you're finding it difficult to know where to begin with this, to get them started. The last skill here is summaries, and these are great ways of wrapping up conversations and also really pulling together any issues or mixed feelings that the patient or the family may have. And here what we can say is, let me see if I've got this right. You're feeling this on the one hand and perhaps feeling this on the other. And sometimes just presenting that can really give people real insights into actually their own behaviour. Or we can say, so what you're saying is. Now let's go back to our poll, and I can see the results that are coming in here. And you were asked, remember, is it better to hear good reasons to adhere to growth hormone injections from you or your patients? And I just need a little bit of help because I
Yes.
can't quite see.
I have the result. I have the result of the poll, and the result is 65% said the patient,
Okay.
and 34% said the healthcare professional.
Lovely, thank you. Okay, so for those of you that said the healthcare professional, I can understand that because of course you need to be supporting people with these good reasons to adhere to their growth hormone therapy. However, maybe, you know, you could consider that it's the patient that we really need to get these good reasons for, because if they're articulating these good reasons, then they're articulating their own motivation to make sure that they're adhering to their growth hormone injections. And that's important because when they go home, you're not going to be with them. You won't be with them to motivate them then. So you need to hear it ringing in their ears before they leave your consultations. So I'd like to share now a couple of techniques with you. And the first technique that I'd like to share is Elicit, Provide, Elicit. And this is where you can use your open questions and your listening and your oars, your skills to be able to make this technique work. So first of all, we elicit, and we elicit using our open questions to find out what people's capabilities are, what their understanding is, what their motivation might be. And really gathering that information is important because that helps you to position the information that you provide and tailor that information to the needs of that particular person. So we often ask for permission to provide information and perhaps signpost. Now, once you've provided that information, it's equally as important to check how it landed with them. So it's good to use your open questions again and ask, what do you think about that? How do you feel about that? How does that sound? Because if there are any barriers at this stage, you really need to know about them to be able to support the patients and the families in moving forward. Now, the final technique that I'd like to share with you is Decisional Balance. And this is really good for dealing with these mixed feelings. And it's interesting where we start with Decisional Balance, because we start here looking at the advantages of not changing. So this is about looking at the advantages, disadvantages, the pros and cons. So starting with the advantages of no change, we might ask, what's on the plus side of you missing some of your injections? Because we're curious, because we're interested, because whatever the answer to that is telling you a little bit more about why they may not be adhering. And then we can move to the disadvantages of no change. And we might ask, what are the not so good things for you about missing your injections? And the answer to that will help us understand some of the mixed feelings that they have, some of the reasons that they might be thinking about adhering better. Then we move to the disadvantages of change, because we need to know this as well. And we might ask, what are the downsides to doing something about this? And some of those downsides could be perceptions they have, or they could be practicalities. And either way, we really need to work with those barriers and understand them better to be able to help people to move forward. And then we can finally ask, what are the advantages of change? And that's your final question, because you want that ringing in their ears. What are the positive points for you about remembering your injections? And it's amazing how people will talk about all the things, the reasons, the good reasons for change that you want to hear and that you know is important to them. So we use these techniques and our skills and our principles of motivational interviewing, and you can use them in your consultations. And in doing this, you can see that motivational interviewing can support the 3 distinct phases of adherence by encouraging that uptake, supporting the implementation because you're tailoring what you're doing to the person that's in front of you, the patient and the family, and of course developing persistence, developing that motivation and that confidence and that belief for change. And I'd like to encourage you to explore motivational interviewing more.
Thank you very much. Well, there are some key messages, and perhaps the most important message is that healthcare professionals need training. Now it's a pleasure to hand over to Chris Davis, who is a pediatric endocrinology specialist nurse. And Chris is going to talk about the pediatric endocrine specialist nurse role supporting growth hormone adherence. Chris.
Lovely. Thank you very much. Okay, so as you just said, my name's Chris Davis and I'm the endocrine specialist nurse. That's my disclosure slide. Right, so what do we actually do as a paediatric endocrine specialist nurse? Well, we do a lot, obviously I'm going to say that, but we support health professionals, families and patients with the aim to improve growth response and adherence to growth hormone therapy. But how does this all work and relate to clinical practice, and what measures can we use in order to support the patients and their families when growth hormone has been prescribed? So we've seen lots of very good presentations and the same words are coming out: knowledge, experience, information, adherence and commitment. So when and how, that's me, will the specialist nurse become involved to support all of these important issues? Well, hopefully we're involved prior to the initiation of treatment. Hopefully we're established, or we're going to establish a relationship with the family and the patient. It makes a huge difference when you've got a family and the patient coming into the consultation room and they have a face that they know, that I've already spoken to them. They come in, they go, "Hi Chris, you know that you're on a good roll to begin with." Be aware of any previous medical history. We'll go into that in the next slide, but be aware that this might not be their first time that they've been in hospital visiting the consultation. Establish whether the family have already accessed information, and if so, is it correct? It's very rare that a family will come into the consultation if they know we're going to be discussing growth hormone and they haven't Googled, they haven't gone on a search engine. What you need to find out is the information they've accessed, is it correct? Establish how keen the family and the patient are to start growth hormone. It's not always happy families and happy patients. We need to see where our starting benchmark is. Ensure sufficient information has been given and offer opportunities to discuss any concerns. Don't give them too much. If you give them too much, the amount of patients who can go home and say, I can remember the first few words, but give them information, the important, that they can then go home, build on it and phone us, I hope. And give growth hormone device choice if possible. That's not, as we've heard now today, it's not always possible. It depends on the area, it depends on hospitals, it depends on country. But if you can, it is always good to give growth hormone choice. I'm asked many times. I have a very large area. I will always offer it, but obviously some patients don't want to travel 3 hours down in the road to choose a growth hormone device. So I'm asked an awful lot, what would you choose, Chris? So it's incredibly important, as we were just saying, that you ask the right questions to get the right answers. So, initiation of treatment. Be mindful of the age of the child. The approach is going to be different. If you have a child, say a young lad who's 12, 13 years old, who's not growing, he's been teased a bit in school, his peers are growing more than him, he's going to want that. Most of the time they want to start growth hormone. In comparison to, say, a little child who's 5 years old, they don't understand why we're giving growth hormone. They don't understand why their mum and dad are going to be giving them an injection every night, because they can't see the long term. Be mindful of the diagnosis. I've touched on this. There's a big difference. If you say, for example, you have a child who's had post-oncology. Could have had years of treatment, years of back and forth to the hospital. They don't want any more injections. They don't want to be there with us. Educate correctly. Signpost. If you're educating and you're signposting, be sure you know where you're signposting. Don't just pick up something and say, this looks good. Read it. Read it and know that what you're giving them, the information you're giving them, is going to be correct. Practical issues. We've already discussed that as a parent point of view. Practical issues. It's incredibly difficult sometimes. Where's the growth hormone? Can they get the growth hormone? Is it through the GP? Is it through the healthcare? Practical issues, the child away at weekends? Is it a split family? And regular contact from the healthcare professional. We always need to keep it in contact. And actually when they start off on treatment, we do. So we have starting growth hormone treatment. We have the worst case scenarios, and I'm sure other nurse specialists watching this have had this. So incorrect diagnosis and dose. Hopefully that doesn't happen often. Inappropriate device chosen. That can happen often. If you don't sit with the patients and find out what would work for them, you might choose, or they might choose, the wrong device. The patient does not want the growth hormone. No, some patients don't. Why would a child of 6 want it? Why do they want an injection? There's their understanding. They might have a phobia, as we just said, because of the past. The patient or the family aren't confident. They're upset when they're given growth hormone. Be sure that you know that they have been taught correctly. Patient, family or health professional not committed. This is, as I said before, it's three parts: patient, family and health professional. You need all three of us to work together. And inadequate advice, information, digital tools. So, starting growth hormone, this is an ideal scenario, and hopefully this happens most of the time. The diagnosis is correct and the dose is good. The correct device has been used or chosen. The patient is keen to start the treatment. The parents, the child and health professional are all committed. They're confident in growth hormone delivery, and adequate information and advice and digital tools have been given. So e-health, supporting patients, families and health professionals. When someone said to me not that long ago, do you use e-health? I thought, I don't know what e-health is. What's e-health? What's e-health? Even though I'm not Florence Nightingale, what's e-health? E-health is something we use every single day in our working life, but we don't think about it. Now, I find that health information is enhanced using electronic technology. As I was just saying, you can give information in consultations, you can back it up, you can enhance it by giving websites, correct support groups, the health literature support groups as well, the apps we were just talking. We've had a very good talk from the parents. I will always advise support groups. They've been there, they've trod that path, they've worn that t-shirt, they know the answers to lots of things that we don't. Any type of monitoring system, and young adults and most citizens have mobile phones and a computer. You can go outside today and you can look, and most people have got their heads down within a mobile phone. But with the good side of it, you have this constant availability of clinical information and of your support networks. So how do we keep the family and patient motivated? So this is the question of all questions. Personally, I think regular contact. Keep in contact with them. When we're setting up, we're all in contact. There might be some testing, there's lots of phone calls, we're in contact. When we start them on growth hormone, there's a lot of contact. There could be blood samples, but we do pick up the phone and say, how are things going? But does it continue? We need to reinforce what we've said, the education, the phone calls, the visual aids. Be there. Use the clinic appointments to discuss and show the growth chart. That always goes down a storm with children, because as we were just saying, it's not immediate. The growth, they don't shoot up. I say to my patients, you're not going to start this and you're not going to grow overnight. This is a slow process. But the growth charts, children and families like to look at the growth chart. They like to see that little bit. You can't take the growth chart. You could take the growth chart home with you, but I always think you've always got a door at home. You've always got a door frame. You can mark it. Get children to see how they're growing. Take time. Katie Frost has had a really good talk. Take time to talk to the families and patients. It's not just about ask the right question, you get the right answer. It's ask the right question in the correct format to get the right answer. If you take your time and talk to families in the correct way, you get many answers that you probably weren't expecting. I had a family not long ago who the child wasn't growing. But when you look back, they're picking up the growth hormone, they're getting it from the GP at the correct time. Why aren't they? But when you sit and take time, and I had a chat with them, they're not giving it. They're stockpiling the growth hormone because they don't know how to give it now. They're scared to ask again. They think that we're going to stop giving out growth hormone. On the other side, we had a child who wasn't growing and all of a sudden started growing. I thought, oh, they've used their star charts very well, or they've put their head against the wall and measured their patient. And know what it was? They've actually given themselves a dog. So the use of support groups that we've discussed about, the use of support groups, so good for parents to talk to other parents. And digital devices, discuss the uptake and adherence with a non-judgmental approach. And the apps which we've talked about, the web-based support, I can't be there, we can't be there 24/7, but the internet can. So, overview of maintaining adherence. Adherence decreases in time. Why is that? Well, realistic and unrealistic expectations. It hasn't happened overnight. There's no immediate, the obvious, the response. It's a slow process. They're bored. They're bored with giving it every night and they can't see the difference. The support can ease off. As I said, we're there at the beginning, maybe not afterwards. You need to keep regular contact. And they're tired. You talk to some parents, they're just tired with arguing with their child. It becomes an absolute process every night, watching the time, knowing they've got to give growth hormone, and they are tired of it. Intentional and non-intentional that we've heard from John. Age, motivation, understanding, and what we have, applying support. So we need to apply the support with the practical skills to help us. So long term, so we maintain support and positive relationships with the family and the patient. Everyone needs to continue to work together, ensuring a combined committed goal of optimal response to growth hormone therapy. And finally, by using a personalised approach, technology can be positively integrated into care, supporting all, assisting adherence and optimising outcomes. Thank you.
Thank you very much indeed. So you can see the key role that a specialist nurse in paediatric endocrinology can play in the management of patients. I appreciate that not all centres are able to have specialist nurses, but I would encourage you to consider having some of your nurses become specialised in paediatric endocrinology, and you can see what a key person in the team somebody like Chris is. So let me summarise in one slide some of the key points that we've made. Achievement of good adherence to growth hormone treatment requires knowledge that poor adherence is related to poor growth response, understanding the causes of poor adherence, appreciation of the patient's and family's perspectives, understanding the benefits of electronic tools, knowledge sharing in motivational interviewing, and understanding the contributions of the paediatric endocrinology specialist nurse to patient care. So let's move on now to some of your questions. And we have some interesting questions here, which I have on my iPad. And the first question is, if your patient is not adherent to growth hormone injections and does not want to change, how do you proceed? So this is clearly a difficult issue. I might ask John if you could briefly discuss the approach to a family like that. The child is clearly not adherent, but says, I'm all right. The family says everything is okay. What would you do in that situation?
I think I'll give you a little bit of an answer, and I think some of my colleagues could also add something very usefully. The obvious thing really is to really explore they understand, that position and the implications of taking that position. Do they really know, from the growth charts where that child's going to end up, and are they okay with that? If they're genuinely okay with that, I think probably there's relatively little one can do. If they really understand the condition, the treatment and so on, that's where they want to go. That's the patient's choice.
Yes.
But there may be other issues lurking below the surface, and I think then it's really important to discuss those, maybe real concerns or worries or misunderstandings and so on. And I think, Chris, some of the things I'm sure that Chris has seen can address that.
So really, can I just say, really it comes down to the family and the child, if possible, understanding the basic diagnosis and the basic need for treatment and how they can benefit eventually from that treatment. Okay, now I have a lot of questions, so we need to move on. And the second question is really particularly appropriate. How can I use motivational interviewing if I only have 10 minutes for the whole appointment? I think the answer is that you can't. And I'm very sensitive to the fact that, as I teach in different places, that consultation times are becoming more and more restricted. So basically, it is not possible to deliver motivational interviewing in 10 minutes. I would suggest what you need to do is some degree of reorganization. Now, I know you have 20, 30, sometimes 40 patients to see in an outpatient session. The question is to somehow identify which of the patients are not adhering, which of the patients are not growing optimally, and concentrate on spending a little bit more time with those patients. Because not all the patients will need motivational interviewing. Do you agree?
Yes, I do.
Briefly?
I do agree, because I think it's something that you can just lean into when you kind of get a little bit stuck yourself and you want to be curious with somebody about what's going on for them, and you have just a couple of minutes to do that. Some of my best breakthroughs are just leaning into it. I don't use it all the time, just leaning into it in that moment, just to build that relationship and be curious about what the thinking is of this person. And asking those open questions can be so revealing, because what pops out will really surprise you as to what the barriers might be.
Okay, thank you very much. So there's another question here, and I'll ask Jenny and Rachel if they can address this. How can you help when the child and their parents have opposing ideas of how much they want growth hormone treatment for the child? Disagreement within the family. How do you proceed?
I think the key thing is to try and connect families together with other families, and to, as far as possible, discuss as many different experiences and outcomes. Ideally face-to-face. The annual convention that we have is a wonderful opportunity to speak firsthand to other parents who have probably gone through very similar situations and come out the other side. Even some acknowledgement of it just being a really difficult phase, and just reassurance that it will pass, and it can be shorter. Just through having that reassurance, then it no longer becomes a long-term issue. Picking up the phone, talking to those like yourself,
Yes,
Jenny.
Yeah. Talking to other parents, the support group is definitely would help these conflicting families. They might not always get the right answers, but by talking to other parents, other people that have gone through it, meeting face to face, then it can really make a massive difference to everybody.
Thank you. Chris, have you had families where there's been disagreement within the family?
Have I had family disagreements? Yes, massively. And I think that everybody's trying to protect everybody else. So the family don't really want to be saying he's playing it or she's playing it. The child just doesn't want it, and the health professional is trying to gauge between the two. So lots of conflict, and I think, as you said, it's support from others as well, to know that they're not the only one who's gone through this, and they're not going to be the only one in the future. This is commonplace. This conflict is commonplace.
Perhaps the child that's in, the child is fine to take the treatment, but the parent is the one who's having qualms. Yeah. Again, they can have reassurance about how to best deal with their own issues that they have with their child needing. We have got some parents and families where perhaps the mother is fine with the treatment, but the father feels differently. And obviously, if they can manage to speak to other families in that situation, it enables them, equips them with the tools to kind of overcome their own issues and their own barriers.
And also to see other children much further on in treatment. You know, they may have had treatment for the last 10 years or so, and to actually see the difference that the treatment can make would help greatly.
Thank you very much. Okay, so there's another question from a mother. My child will be 3 in July. He has been diagnosed with Russell-Silver syndrome. We were with the endocrinology team last June, and I'm going back next month. So far, he is following our growth pattern, going back now to see how he has grown. What questions would the mother have, what appropriate questions would the mother have for the team? So maybe as a pediatric endocrinologist, I can just think about this. Essentially, children with Silver-Russell syndrome often do not have good catch-up growth after birth. And they are a group of children who need following carefully, because potentially their height can deviate from the normal centile lines. So I think my advice to you would be to make sure that the child is accurately measured in the endocrinology center and accurately plotted on the chart, and that it would be appropriate for you to become concerned if there is evidence that the child's height is deviating from the normal centile lines. And that would be the time to start discussion of possible growth hormone treatment at some point. If the child is growing parallel to the centile lines, that is a good sign, and I would say in that situation growth hormone treatment would probably not be indicated. So let me see what other questions we have. Can children and their families benefit from referral to psychological support or counselling? John.
Well, the short answer is yes, particularly in some of the situations we've heard about where there may be conflicts within the family, perhaps serious resistance from the child, needle phobias, all the things which have clear implications for psychological support. So the short answer is yes, but obviously it depends on where you are. In some hospitals there is very good support and very good referral available for those issues, but there is certainly a lot of expertise out there. But my sense is that the specialist pediatric nurse can often provide that support too.
Yes.
And I think I think there's a danger in jumping into psychological referral too early, because people can get a little bit pathologized and feel a bit stigmatized by that.
Right. So do you think that a key point is for the healthcare professional, either the doctor or the nurse, to be able to recognize those psychological issues that are too complicated for them to deal with, and that would be an indication for referral?
Correct. Yeah. I think that's the key issue.
Yes.
And
I was just, yes, because we do get involved a lot, because not everybody, and we certainly don't have a psychologist attached to the team. And these issues are ongoing, but what we do is we meet with the psychologist quite regularly, not attached to the team, but the psychologist for Child Health, and we discuss patients so they can give us strategies. They can, because we're always worried as nurse specialists, we're not psychologists, that we're going to say the wrong thing, that by saying a certain thing, we're going to make things worse. And I'm sure that you, parents, have felt that as well. You don't want to do the wrong thing. So if you don't have a psychology service, I would say try and access a psychologist to discuss specific cases regularly so they can give you guidelines on how to approach the parents or approach the child.
And this really comes down to having a multidisciplinary team really working for the optimal response to treatment in these patients. Let me ask Jenny and Rachel, if a mother phones up and over the phone you get a sense of true psychological abnormality, would you recommend to them that they seek the advice of a psychologist?
Depending on the actual phone call, yes. If it's sort of just general, my child doesn't want his injection, it's stressful, it's causing all sorts of problems, then it would be a case of, well, why don't you talk to other parents who are going through that? But yes, if there is a real problem, which sometimes there is, and sometimes it does need to be referred on to a psychologist, so we would say see your endocrinologist, and hopefully they can point you in the right direction to the correct support, because it certainly is something that we're seeing more and more of, especially as the child gets older, through adolescence, etc. They do seem to be, finding it quite difficult to get through. So certainly support in some cases is a definite.
So I want to come back to motivational interviewing, because this seems to me a really new aspect to many of us of the management of growth disorders. And the fact that the healthcare professional, whether it's a doctor or a nurse, needs training. I think this is important. Katie, have you noticed any resistance from either doctors or nurses in accepting the fact that they need to be trained in some situations?
I haven't experienced that resistance with healthcare professionals. I've experienced a genuine interest, and that this could be a tool in the toolkit that they can bring out. And I just want to say that I'm not a psychologist either, and I'm aware that I'm using something that is a behavioural change tool. And I think it's about going into it, easing into it gently. I just started with the principles. Then I started to play with the skills. There's no danger in doing that. And then I started to read and understand and do courses and do training. And then I wanted some supervision. And I think it's just dipping into it and seeing how it is for you.
Thank you very much. I mean, I think one key message is that if adherence is going to be addressed effectively, it does take time. And of course, we all have time constraints. And in some parts of the world, there are so many patients that need to be seen that the time for a consultation may be 5 minutes or something like that. But if we are going to improve growth responses, we need to recognize that adherence is a key problem. It's very easy simply to fail to admit that some of our patients may not be optimally adherent. And I think many of us have done that in the past. I certainly have. But now this is very much part of new management, a new approach to management, linking e-health tools with a personal human approach. And I think that is how we can progress in a very, very positive way. So we're now coming, I think, to the time when we should look at our post-assessment questions. So let me read out. This is question 1. I am familiar with the latest psychological model, this COMB model, explaining why patients may struggle to adhere to medication. So you can either strongly agree, disagree, or strongly disagree. So would you like to think about answering this question? And hopefully your mind is now open, all of our minds are now open to this question of this psychological model. The next question, patients' self-reported adherence to growth hormone injection is higher than measured by an objective electronic device, or lower than that measured by an objective electronic device, or about the same. And let me remind you that over time, the percentage of good adherence will decrease. And of course, families may be very conscious of this, but they may find difficulty in actually owning up to the fact that their child is missing injections. So perhaps you could think about this question, and I think this is one area where, and I'm not trying to answer the question for you, but this is where the electronic device can make a significant impact. Let's go on to question number 3. 2 of the core skills needed for motivational interviewing are. So basically these 2 key skills are included in one of these 4 questions. Directive questions and summarizing, goal setting and assertive communication, open questions and reflective listening, and goal setting and affirmations. So we've got a few minutes, and let me come back to Katie briefly. Do you think our listeners are going to get this right?
I think that they're going to look at it and think, well, there's some aspects in all of those answers that are to do with motivational interviewing, and and they would be right in that.
They would be right, but just looking at that critically, you don't want to be directive, do you?
No, that's definitely not on.
If you're directive, you're telling patients what to do.
Yeah.
And that is something I think which we've learned throughout the webinar should be avoided. Goal setting and assertive communication. You want them to set goals, I think, don't you?
We do. And actually, if assertive communication is about really, being adult to adult with people and having respect for ourselves and others, then there are a lot of elements of assertive communication that come into motivational interviewing.
Right. Open questions and reflective listening. It is always important to listen. When you assess a patient clinically, you need to ask questions, but you also need to listen to the answers. So listening is extremely important. And again, goal setting and affirmations. Affirmation is important. Affirmation is a way of boosting confidence, boosting self-esteem, letting the family feel that this is an issue that we can do well at. And that's also important. So let's look at question number 4. And really, this is just something for you to think about as we come towards the end of this webinar. How might this event, our webinar, influence your future practice? It's really been a privilege to talk to you and to have the opportunity to link with you, and we thank you very much for logging in. Are you going to consider using a screening questionnaire to identify causes of poor adherence? Will you be seeking further advice, perhaps seeing if there is somebody linked to your institution who is trained or knowledgeable in motivational interviewing? Will you be able to help your patients find peer support groups, such as the Child Growth Foundation? We've heard really what a key role the Child Growth Foundation, these patient support groups, can play, because families will communicate much more openly and I'm sure Jenny and Rachel will agree, with a patient support group than they will with either a doctor or perhaps a nurse in the consultation environment. Will you look at the possibility of using e-health tools? E-health tools are going to become more and more influential in all of our lives. I think it's time that we actually looked at that to see whether they can positively help in growth disorder management. Or basically, have you decided that you're doing okay, I'm not going to change my practice? Of course, we respect that. And but maybe, hopefully, this webinar has given you an opportunity to think about some of these topics. So I'd like to finish by thanking you very much for logging in. It's been a pleasure to spend this time with you, and it's been a privilege for us. And the contents of this webinar will be available, and you will be informed where you can link and join the contents of the webinar. Thank you very much.